with which is the Rural Opioid Technical Assistance Program, and that is through our University of Maryland Extension. And we offer many courses and many services, which we'll bring you up to date on at the end of this presentation. We are going to talk today about the opioid public health crisis, kind of what is an opioid, how did we get to this point, where are we now, what are some things that we can do, and what are some best practices to address this crisis. I like to call this course everything you ever needed to know about opioids, from soup to nuts. So we are going to cover a lot of information, but this is a terrific course, and I hope that you enjoy it and get something out of it today. And at the end, we will ask you to evaluate our course so we can know how we are doing through ROTA. If this was helpful, what suggestions you may have, we welcome any of that, as well as questions throughout the presentation today. I have Julie Slivka. She is my partner today, and she will be helping me to monitor the chat, the questions that come up, any kind of information that maybe needs to be posted. So we welcome you, and we're going to go ahead and get started. So, the opioid public health crisis. As we know, this in general addiction, but the opioid crisis has affected us tremendously in this country and really across the globe. It crosses socioeconomic, ethnic groups, gender, religious affiliation. This is affecting all of us. So when we are talking about addiction, we'll take a little bit of a introductory overview of addiction. Addiction is characterized as substance use disorder. It is a chronic brain disease. Like any other chronic disease, addiction should be treated medically. When we look at heart disease, when we look at diabetes, we look at them as chronic diseases that can be managed and treated. There are differences between those who use substances and those with addiction. And that is because addiction actually changes the brain structure and function. One can be dependent on a substance, but it is when we see that absolute change in the structure and functioning of parts of the brain is when we can identify addiction. So what began as a choice is then hardwired into the brain as critical for survival. I encourage you all to take the course next time, I believe it's in 2 weeks, which is, entitled The Brain and the Disease of Addiction. And that goes much more into detail about how addiction actually changes the brain and what that means, what that looks like, and how it can be possibly reversed. So I encourage you to look at that course next week. That's a really good one as well. So we have an estimated 23 million Americans living in recovery from addiction. We have 20 million that are currently symptomatic with addiction. So 43 million Americans estimated are affected in one way or another directly by addiction. So when we talk about opioids, we're talking about several different kind of a range of what type of opioid they are. So for instance, we have natural opioids. Natural opioids come directly from the poppy plant. You can see one right there. They grow in very hot, dry climates. Drugs that are considered natural opioids include drugs or medications like morphine, codeine, and actually just opium directly from the plant that is smoked or injected or inhaled. So when we think of morphine, most of us are familiar with that through hospitalizations. If you have surgery of some kind or an injury of some kind, you've probably received morphine through a IV. It is a very effective painkiller when it is used properly. It's very little risk of harm from getting morphine in the hospital. Sometimes people might have a little bit of withdrawal, but that's just because of the strength of that drug. But It's very strong, but it is very helpful and very commonly used medically. Codeine is another natural opioid that you see a lot in cough syrups, cough formulas. So again, very safe to use under the direction and monitoring of a physician. So we go to the semi-synthetic drugs, and those are opioids that have some aspects of the natural opium in them, but they are also kind of modified synthetically in a lab, so they can be used probably for wider purposes or applications, easier applications. So for instance, Vicodin, Percocet, oxycodone, those are medically used for pain management very effectively. And someone can take them, orally as a pill as prescribed by a physician. Now, we are also, as we know, and we'll talk a little bit later about how these prescribed medications that are easier to use, fairly easy to access for patients are also have also been what has kind of kicked off this crisis in our country. We'll talk about that a little bit. At the bottom right, you see heroin. Up until recent days, probably the last few years, heroin was very commonly used. It's a illicitly distributed drug. There is no medical use for heroin whatsoever. Heroin is about 50 times more stronger than morphine. So that is always a concern, and it is something that is very highly addictive. Okay, so on the right, we see fully synthetic drugs. So those include obviously fentanyl. Fentanyl does have medical use. It is used in hospital settings for pain management. Under a doctor's, again, supervision or monitoring, it can be used carefully. We have fentanyl patches that people use for pain management, and even IV or pills. Where it gets a little dangerous now is that we have a very widespread use and availability of illicit fentanyl, illicitly produced, illicitly manufactured fentanyl. We'll talk a little bit about that in a while, but what we are seeing right now is that fentanyl has just pretty much outpaced heroin. Heroin is almost rare now in use compared to fentanyl. And also methadone is a fully synthetic opioid. That is something that is used for treatment of addiction to opioids. So it is used in special clinics, medically assisted treatment clinics, where people can kind of substitute a prescription for methadone while they are trying to recover off of other opioids that they're addicted to. That's kind of like a harm reduction method, treatment method as well. Very effective in some people. For some people, I'm sorry, I'm having a hard time getting my words together today, so I'm gonna move on to this. Here we go. So prescription opioids, like we just said, they can be used to treat moderate to severe pain, often prescribed following surgery or injury. Increased acceptance for the treatment of chronic non-cancer pain, despite risks and the lack of evidence about long-term effectiveness. So what this is saying is that, when these drugs were used very selectively with patients hospitalized under direct doctor care, they were very effective for specific conditions. But maybe 20 years ago, which we'll go through the process of this, but people started going to pain management clinics. They started prescribing larger amounts of opioid pain medication, despite not having a whole lot of evidence about how effective they were in the long run. Okay, so anyone who takes prescription opioids can become addicted. It does not discriminate. They are very highly addictive drugs. As many as 1 in 4 patients that receive long-term opioid care struggle with opioid addiction. So again, if someone is getting legitimate care with their physician, it's imperative that they discuss this. They make sure that the physician is checking in with them. They're checking in with the physician. It's very closely monitored. Okay. So best practices. Anybody who is taking prescription opioids for longer periods of time or in higher doses for pain can increase the risk of opioid disorder, use disorder, addiction, overdose, and death. It's important for patients and providers to discuss opioid use and consider alternative therapies. There are many alternative therapies out there, and there are many good websites out there. There's a lot of information about alternative methods for pain relief. If necessary, people should talk with their physicians about, can I take this prescription for a fewer amount of days? Can I get by on less medication, et cetera? And we'll close today with talking about some of those options as well. So fentanyl 101 has been used in clinical settings, like I said, in hospitals, hospital settings, surgical settings, emergency settings for post-surgical or pain management. Fentanyl, illicit fentanyl, this is not necessarily the medication, but the illicitly produced fentanyl is the primary driver for the overdose health crisis today. It is cheap to manufacture. The components are very easy to acquire. It's very concentrated. So a small amount of fentanyl goes a long way in terms of producing the effect that people who misuse opioids are looking for. So somebody with probably a decent high school to maybe college knowledge of some chemistry can very easily access some of the chemicals and components that are needed to produce fentanyl, with much of it over the internet. Fentanyl via the street market comes in white, gray, tan, or sometimes even a pinkish tone color, can be in powder, can be injected, smoked, or snorted. But what we are seeing now is more of the pill form of fentanyl, which is looks like many other pills that people may be wanting to get. So for instance, we are seeing a lot of sold over the internet, produced illicitly, distributed illicitly, of course, fentanyl that is being sold or marketed as either Adderall or OxyContin, oxycodone, even Percocet. It looks exactly like those medications. So somebody may legitimately, I guess you could say, go on the internet to try to find medication for pain and are getting pretty much pure straight fentanyl cut with other junk, but they're getting fentanyl. They're not getting any of the other medications that they need or may be looking for. So it's been found in drugs like heroin, cocaine, meth, and also pressed pills. So fentanyl has been found, let me show you the slide. There have been findings of marijuana being laced with fentanyl, because remember, it is a powder, but it can be formulated into a liquid and sprayed on pretty much anything. So people could spray it on marijuana. Technically speaking, I suppose you could even spray it on tobacco or other means of getting it. So we have to be very careful with fentanyl. It is pretty much everywhere and available very easily. Okay. So pill presses for counterfeit drugs seized in record numbers. We're seeing a lot of this on the news, that people can get these fake oxycodone pills. They can get fake Adderall. It does not take but about probably 2 milligrams of fentanyl to be fatal to an adult. So this is extremely serious. And like I said, people can go online and buy the pill presses. They can buy any of the substances that they need. They can find substitutions for maybe some of the ingredients that are used. So this is pretty widespread. We are also seeing, you'll see this, fentanyl is 50 to 100 times more powerful than morphine, but you'll see this looks like Pez, so it looks like candy. Julie and I were talking before this that we've heard news reports very recently about what they're calling rainbow fentanyl, which is small round pills, but they kind of look like something that would look like Skittles or candy to a child. So that, of course, is very concerning. So fentanyl is being disguised to look like other drugs or look like other things, and it's being marketed and sold as other medications. Okay, so this photo is showing if you had a small vial on the left, this would be a lethal dose of pure heroin. If you look on the right, this would be a lethal dose of fentanyl, a few grains of, that look like salt. It does not take much fentanyl to be fatal. So even though it's being cut and, processed into pills or even into powder, there's not a careful formulation to, so to say, that, it's evenly distributed among the supply. You could have pills that don't have much fentanyl at all. You could have pills that happen to get the bigger part of the fentanyl. That's, there's no regulated or regular dose, which is what really makes it so dangerous. Okay, do we have any questions so far about this part?
We had a couple comments about the surprise that the fentanyl is being found detected as a spray. We've also put some questions out to the group to see what people are seeing in their communities, and they are seeing fentanyl being cut with cocaine, marijuana, and heroin, and now we see a rise in xylazine too. So
yes,
as we can see, the issue is very prevalent.
Yes, and it's surprising. We've had some incidents in our community where police have been called for reports of an overdose, and people say, well, all we did was cocaine, because cocaine is a stimulant. It's completely opposite in terms of effects from a lot of these opioids. So, and they're using Narcan, and people are coming back and they're finding that the cocaine was laced with fentanyl. So, then you're getting a double whammy, because you're getting the downer effects from the opioids, and you're getting the racing heart and the blood pressure racing from the cocaine. It's called a speedball, and that is obviously not a good thing. So again, yes, we are seeing a lot of that. I'm surprised people have heard of the rainbow fentanyl, and then the word is getting out there, which is fantastic that we're becoming more aware. The marijuana is very concerning, because we are getting ready to probably legalize marijuana in our state and across the country. And that is dangerous, because we have had a few cases that we've heard of in this, in the Medshore area, of young people smoking marijuana, and it was laced with fentanyl. Thank goodness it wasn't a fatal dose, but again, fentanyl is everywhere. And why is that? Because it's very cheap and very easy to manufacture. Okay. So let's move on to the opioid overdose epidemic. Okay. So now we're going to be getting into some really interesting kind of numbers, and you can see how the rise of this has just been amazing. So I'm going to try to get this off of my screen so I can see the numbers on here. Okay. So overdose deaths through 2020. This is in the US. These where you can see in 1999, we had total overdoses of 16,849. When we got to 2020, it was, according to my sheet here, because I can't see the edge of the slide, 93,422. So it's been a steady increase in overdose deaths. In 2020, overdoses were the leading cause of death by far, even outpacing cars and guns together. Opioid overdoses were 69,714. That was 75% of the overdoses. Now, these I pulled from the recent Maryland data that comes out from the State Health Department. So the total deaths in 2021, just to give us a more, more updated view, were 107,622, and that was opioid US deaths, which was an increase of 15% over 2020. Okay. Okay, Julie, I might need you on this one because I've got everybody's pictures on my right-hand side of my screen here, but we can see the fatal doses all the way through at the end. What's that number for 2021?
2021, we are looking at 2,765.
And what we know is these that were opioid were how many?
It's cut off a little bit,
Yeah.
but opioid related, if I remember correctly, and I can put the report in there, I mean, it's over 90%.
Yes, exactly. So we can see, you know, that the desire for opioids has really gone up in communities. Here's another one that are Maryland slides. I had them written here, but I can't seem to put my hands on them in my notebook. But we can see that, you know, the rate of overdoses in Maryland has gone up. Fentanyl related deaths tops everything else, even over heroin related deaths. So here is why that is happening. This is probably one of my favorite slides in here because it's, when I first saw it, it took my breath away. We have three kind of lines there that are showing progression over the last, you know, almost 20 years, say, up from 1999 up until where we are today. So that dark blue line at the very top shows prescription opioids. So, you know, pretty much it took a while. Hang on one second and let me just get this. Okay. We started with prescription opioids. You know, there was not much use until 1999. They were all pretty much equal, fentanyl and heroin, where prescription drugs started to increase. And we'll talk about why this was in a moment. But this was the first wave of opioid overdose deaths in our country that we really started to see. So this started with increased opioid prescribing and overdose deaths due to prescription opioids being more commonly, we talked earlier, commonly prescribed for other things other than in hospital care, so pain management and those kind of things. The second wave began in heroin, and we can see the prescribed opioids, you know, have gone kind of up and then leveled off toward the end of this chart. Heroin has always been around, and again, that kind of followed kind of a, you know, predictable pattern, no real changes there until 2010 or 2011. And we'll talk about why that was, if you remember that. And then the third wave involves the synthetic opioids, which is fentanyl, and you can see how that has just taken off. So why has this happened? Well, most of the increases in heroin use was increased availability and lower pricing. Also in 2010, this was when 2009 and 2010 was when prescribing began to be monitored. So for a long time, the prescribed medications, let me see if I can go to that next slide. Opioid prescribing practices. Around 1999, these prescribing practices were starting to be monitored by governments. Prior to that, we had the drug manufacturers, the pharmaceutical companies, really excited about having this new drug called OxyContin, and they wanted to get it out to prescribing physicians, not necessarily in hospitals, but in primary care and other settings, to start using this for people who were having, you know, back pain, chronic other pain. Okay, so the prescriptions tripled in a very short period of time. And what happened is many states, West Virginia was one of them, some of the New England states were tremendously affected by just this flood of pharmaceutical OxyContin and other pain medications just, you know, being prescribed for everything. So what happened was, and we've seen some of these lawsuits that have occurred as a result of that, right now in the last couple of years, we're finally having some of these pharmaceutical companies being held responsible for just the flood of these drugs going out into, small practices and medical personnel. So what happened was that not too long ago, in the probably late 90s to early 2000s, we started having the programs like PDMP, which we call Prescription Drug Monitoring Program, and other programs through the government, which were monitoring the prescribing practices of physicians and tracking. And there were, regulations put down that physicians could not prescribe these as openly and as frequently as they were. So that they began to really come down on that in terms of prescribing practices, regulations, et cetera. So people all of a sudden who had been on these medications for pain, maybe several years, were being told by their physicians, well, I can't prescribe this anymore, so I'm going to have to cut you off. And we know that these medications are very addictive, especially with use over time, and even if they are prescribed safe medications. So people were turning to other ways to meet the needs that they had to satisfy their addiction needs and what was going on, because we know the brain is processing it differently now. So long story short, they were turning to drugs like heroin or illicitly found prescriptions. So that is why we saw that heroin line go a little bit up until we got to fentanyl taking over, because all of a sudden fentanyl, somebody had the idea to, start mass producing illicit fentanyl, and fentanyl is cheaper, it's easier to get, it has a more powerful effect than heroin. So that is how we then, that third wave showed people who started with the prescribed medications, went to using heroin and other things they could buy on the street, to fentanyl. And that fentanyl has just gone sky high. So that is kind of why we are where we are now. Okay. So paths to prescription opioid use disorder or addiction. This is always a pretty interesting slide as well, because we know, obviously, we have the prescription misuse on the left-hand side. People were getting prescribed medications, then maybe they were sharing them with others. We know that people that use or misuse prescribed opioids get their first taste of that usually with medication of some kind. So they may get it from somebody's medicine cabinet, they may be sharing it with a friend, buying it from a friend. Access to even prescribed medications is pretty widespread. We know of people that go to open houses in our county, at least, and go through medicine cabinets looking for any kind of opioid painkiller that may be in there. So the access is something that we'll talk about later, that is something that each of us can make an impact on. There are cultural and societal reasons behind this. We as a culture in the US, we don't particularly like pain very much. So worldwide, we have a higher perceived rate of pain than other countries. So in our country, 34% of us as Americans report that we're in extreme pain or severe pain or frequent pain. So we just like to medicate in our country. We are, a small percentage of the world's population, and we use the majority of the opioid painkiller drugs that are out there. So and it's very easy. I've done a presentation on this in the past where we look at TV ads, or we look at media, and how often medications are advertised and marketed. If you watch, the 6 o'clock news at night, you're probably going to see 5 to 6 commercials for medications of many different kinds to treat every ailment that's out there. So it's kind of that message that gets across that, well, I could just get something to fix whatever this is I have. or I can use this because it'll be easier to just take a pill than have to do other things to deal with my pain or my condition. So, you know, these medications taken again, you know, prescribed, monitored, you know, you check in with a physician, the physician checks in with you. That is good. It is wonderful that we have that technology, but we, as a culture, we have to look at how we react to pain. Okay, pain is a fifth vital sign. There was a time during the 90s that pain, if you went into a hospital for, say you would go to the emergency room and they would ask you, they would check all your vital signs, and then they're going to ask you, well, what's your pain level? From 1 to 10, what's your pain level? And so the hospital started looking at pain as a vital sign and trying to get people's pain down as much as they could, trying to regulate that or treat that. So it is difficult to measure. It's a very subjective measure. You know, on a scale from 1 to 10, somebody's 5 could be another person's 8 or 9. So that became a problem when the hospitals also during that time, healthcare systems in general, were looking at quality care, quality management. Are people happy with our service? Are they feeling they're getting what they need? Are we going to get good ratings? And so if, you know, if somebody is in pain and you're making them not feel pain for a while, they're going to give you probably a better rating than some of them are getting now, where patients are going in and they're not immediately being given pain medication, even if they ask for it. And so then, of course, they're going to say, this is a terrible hospital. I never want to see this doctor again. So it's that whole, you know, quality assurance piece that came in that is still kind of being worked out. But pain is no longer measured anymore as a vital sign. So it's maybe pretty rare if somebody goes to the doctor and is asked on a scale of 1 to 10, or if they're asked that, it's, you know, not necessarily meaning that the pain will be the first thing that's treated. Healthcare incentives, we know, we talked earlier that the pharmaceutical companies gave huge incentives to physicians to prescribe oxycodone and other things back in the early 90s. So in the 90s up to 2000. So, you know, if you're a physician and you're in a small town and, you know, you have, I'm not blaming physicians at all, because I, you know, think they were put in a very difficult position. But if you are prescribing, you know, and somebody is giving you incentives like, you know, free vacations or free lunch for your staff, or, you know, free, you know, we'll give you these medications free. You don't have to, you know, charge your patients. You can give them as samples, all of that kind of thing. Those incentives were very heavily in place at the beginning of the prescription crisis. And then we have something like dosage and duration. Again, this is something that longer durations, higher doses are going to cause a higher risk for addiction. So physicians are getting much better at giving smaller doses, smaller period of time. It used to be you would go to the dentist and get a wisdom tooth pulled and they would give you a whole nice big bottle of Percocet. Now they don't do that. They might give you a few. They might say, you know, let's see if this will get you through a couple of days and then we'll check in again. So, you know, there's been some pulling back on that just open, you know, prescribing. Now, I'm sure many of you probably have experiences with that, where you have an outpatient surgery or dentist and you still get that nice big bottle. And we're going to talk a little bit later about, you know, what you can do to make sure that that doesn't get into the wrong hands. Okay. Any other questions about this? This has been a lot of information. Okay. Let's see. All right. So go to the next slide. So when we talk about youth, the age of 15 is the age, the mean age of first misuse of opioid drugs. When we look at older teenagers and young adults, it's been identified, you know, through research and interviewing that it's 15 is the age of their first misuse, and we certainly have seen that reflected on the midshore here. Why is that? Well, they perceive prescribed drugs or pills as being lower risk than other, you know, street drugs that you might get, like heroin. So if I'm going to use something, I don't want to use cocaine, I don't want to use heroin. I'm going to start out with something that I don't think is going to hurt me because, hey, it's a medicine. It is socially acceptable with peers. What we're seeing in general is that, we talked about how people will go into other people's medicine cabinets, how young people will, raid the medicine cabinets in their homes or their grandparents' homes and just kind of gather up what's in there, even if it isn't necessarily an opioid, but they will share pills with their friends. And sometimes they'll have what they call farming parties, PHARMING, where everybody will bring what they happen to get out of a medicine cabinet and share amongst themselves a variety of these medications. So it is very socially acceptable. They just don't think that something that comes from a medicine, a doctor, or something that is medicine is going to hurt them. So they get it from family or friends' medicine cabinets. Now, even though they may not be just getting opioids, we have to be concerned, obviously, about young people taking a blood pressure medication or a thyroid medication or diabetes medications or other medications that are not prescribed for them. And we talked a little bit at our last presentation about the Generation RX, the medication safety. Any medication can be dangerous to the person that it's not prescribed to. We have to be very careful about what we give to others or what we take. It's formulated for that individual who it's prescribed to. So we have to be very careful about that with youth. And of those who started at age 15, the overwhelming number of people 18 and older who are using street fentanyl or heroin say that they got their first exposure to it from somebody's prescribed pills. So, okay. All right, so this is a slide that is going to kind of happened to my page here, so I'm just going to go through. We're going to look at, and this, I think Julie's going to share this for you so you can have this list. What are we seeing when we're looking at opioid misuse? What are the signs? What are the symptoms that we may notice? So physically, we may see things like constricted, really pinpoint pupils. They may be wearing long sleeves when it's very warm outside to cover up track marks. They may be itching, scratching a lot. There may be itches and scratches or sores on their skin. Just overall looking healthy, maybe very pale, maybe tired, maybe lethargic, lack of hygiene, slurred speech, poor coordination when we're looking at misuse of opioids. And this is generally across all opioids. Health, you may see weight loss, nausea or vomiting, or constipation. Women may not be getting their period, their cycles may be off schedule. We may see and often see depression because these drugs are depressant drugs and they are affecting the part of the brain that controls, it's called the pleasure center, and we'll talk more about that in the next presentation. But so when the chemicals in your brain that control whether you're going to be happy or sad are being completely affected and changed by these drugs, you are going to see some depression, changes in appetite or sleep. Behaviorally, we may see things, because sometimes the health things we may not know. Somebody may not share that with us, but we may see behaviors, somebody nodding off all the time. They may be using laxatives. They may be with people that you don't know. As parents, you may see, they may not be hanging with the friends that they've had a long time or doing the activities they used to do. They may be all of a sudden with a new group of friends. They may be even getting a little more secretive about the time they spend with others, where they're going, what they're doing. Obviously, when any addiction or substance use disorder is in play, we see problems in schoolwork, spending more time away from home, wanting to be maybe more secluded, more separated from family. May see legal troubles, and again, that loss of interest in things that they used to do. What you may notice in your home, you may notice things like you're missing money, you're missing valuables, you're seeing things that you purchased, you don't know where they are, and you know, somebody may have gotten those receipts and returned them to get money to buy drugs. More frequent or secretive phone calls or conversations, bottles of vinegar or bleach or cotton balls to clean up. You know, let me get to my last column here, which is cut off for me. We may also notice or find kind of the tools of substance use, particularly injection use. You may find empty baggies or papers folded into small little packets, you know, tiny small packets or envelopes, spoons with burn marks on them or missing spoons. I've had parents in the presentation say, well, I don't understand why all my spoons are missing. Where are my spoons going? Is that a sign? Well, it is a sign, because when people use a powdered substance to inject, they put the powder into a spoon, a little bit of water, hold it over a lighter or a flame, and it will, you know, develop into a liquid substance that the powder will dissolve, and they'll be able to then inject that or spray it. You know, things like loose change, maybe dollar bills. Sometimes, you know, in the cocaine days, especially, we used to see a lot of people snorting cocaine out of a dollar bill or straw. Again, aluminum foil or gum wrappers with burn marks. Sometimes they'll dissolve the drug in foil, small pieces of foil. Straws or empty pens, syringes or tourniquets as well. So those are the things that we may notice. And what we always say when we do presentations like this is we want to look for patterns or repeated signs or symptoms. So if one thing shows up, we don't want to assume, but we want to then say, I'm going to keep an eye on this. So, you know, if your child is, you know, all of a sudden they're changing friends, they're having some school issues or work issues, that may be something that we want to keep an eye of. And then if we may notice some of these physical signs or health signs, you know, we want to put it together in a pattern or repeated things that we're seeing, because especially teenagers can be very moody and switch friends and not want to deal with the activities they used to do. And it may not necessarily be a substance use issue, but we always want to kind of keep track of things. I went to a workshop one time years ago, and they would suggest going into your child's room, not necessarily to search, but to just look around and observe, you know, what's hanging on the walls. Did it used to be posters of baseball players, and now it's posters of, you know, heavy metal bands or marijuana leagues or something like that, you know. Look around and just kind of get a feel for where things are with your child. It doesn't have to be a searching thing. We can get so much out of what's around them, what's in their room, what kind of clothing are they wearing? Are they wearing clothing that promotes drug use? And there's a whole lot of workshops on that kind of stuff too. You know, clothing lines and t-shirts and posters and things that as parents to us may look totally normal. We don't understand that there are brands out there that are actually named for particular drugs, and these kids buy them to promote the drug use. There's even t-shirts and hats out there that have little pockets and backpacks, little stash pockets built in that you would never as a parent be able to find, but it's marketed as, you know, it has this little stash pocket for you to put your drugs in. So again, we need to be aware, we need to keep our eyes open. We don't need to assume, but we need to at least be open to what we're seeing and remember it and see if it makes sense to put it together with some other things. All right. So best practices and solutions. There are, you know, obviously a wide range of solutions for this issue. Treatment and recovery obviously is the biggest. We just don't really seem to have enough treatment available right now, but you know, there are many agencies and you know, internet searches and resources is what I'm trying to say, that are out there that can help people with maybe identifying, is this an issue? What do I do from here? Where do I go? You know, how do I confront my child? All of that. So I encourage you to look into health department information and websites. OMPP, which is the Opioid Misuse Prevention Program, is pretty much statewide, I believe. I know in the Midshore, there is one shared project within the 5 Midshore counties. And they have an excellent website called I Wish I Knew Midshore.org. And that will give you, you know, solutions for parents, ideas, resources, what to look for, what to do if you find something, all of that, as well as some of the other preventative things, which we'll talk about in a moment. Check my time here. So harm reduction. Harm reduction is not treatment. It is reducing the harmful consequences. So something like a seatbelt, we could consider as harm reduction. It mitigates or lessens the consequences that are associated with the behavior. So harm reduction could be Narcan. We'll talk a little bit, I believe, about that at the end. It could be, you know, we have sometimes Narcan, fentanyl testing strips, where if somebody is a casual user, say of marijuana, they can test and make sure it doesn't contain fentanyl. So those are harm reduction, and many, there are health departments and some other agencies that offer harm reduction methods. Reducing the stigma, we offer an excellent course on stigma, how we can remove the barriers for somebody getting help with their disease, because we know that when people feel stigmatized, they are not going to be comfortable asking for treatment, and that goes for their families as well. So stigma is really a huge factor in people's willingness to get treatment. So we encourage you all to look for that course as well. Screening and early intervention, obviously this used to happen in the schools, not quite so sure anymore with COVID and where things are with that. But obviously the early that somebody is identified with a substance use issue, the better off their chances are for recovery. Safe prescribing, so we talked about that. You know, there are, you know, ways to talk to a physician. Sometimes it's hard for some people to feel comfortable asking questions of their healthcare providers, but that OMPP site, the I Wish I Knew site, gives some really good tips on how to do that. I think the state of Maryland also has a campaign, it's just called Talk with Your Doctor, and it helps people feel comfortable and feel prepared when going to, you know, in a conversation with their healthcare providers. So, you know, you can ask about alternatives, you know, how long do I need to take this medication? What is it being prescribed for? How do I know if it's working? All of those things are things that we can do to help a doctor be, you know, safer in prescribing that medication, because we need to look at physicians and other healthcare providers as our partners in our own health. Prescription management, we'll talk a little bit about that, but, you know, safely using, safely storing, and safely disposing of prescribed medications. And I think there's some more of that toward the end here. If not, I'll come back to that. You know, education and prevention. We have prevention offices in the health departments. There is some substance use education in the schools through the health education piece, but certainly staying informed and doing reading and going to some very, you know, reliable sites on the internet, the CDC, SAMHSA, all of those. And obviously we talked a little bit about the data and prescription drug monitoring. When somebody has written a prescription right now, that prescription goes into this PDMP system and it is tracked. It is tracked for, you know, is the prescriber following what needs to be done to make sure this is done correctly and safely? And are people who are prescribees, you know, who are getting the medication, using it and not, you know, trying to use a prescription and taking it to several different pharmacies. So the pharmacies are also tracked in this, just for safety. Okay. So patient recommendations. Okay, so let's go to this. We talked a little bit about being a patient, but how do you manage these at home? So the majority of youth, we've talked about that. The majority of youth get their access to pain medications through a family or friend's medicine cabinet. Sometimes people are going, like I said, to open houses. Sometimes they read the obituaries, and if somebody died of cancer or they know of a death in their community, they may try to go and access those medications in the home. So there are many ways that people can find out how to get these medications. So they mostly get it from somebody else. So we want to look at storage, securing medications, disposing of medications as soon as we are finished with them, if they're expired, if they are no longer needed. If it was a prescription that the doctor said, well, I'm going to give you something else, so you don't need this one, we're going to change your prescription. We need to get rid of those medications. So in terms of storage, you can use medication safes, locking pill bottles, put it out of the reach of my coworker says of little hands and little paws, because we don't want pets getting into it as well. Many of the health departments through this OMPP program can give you locking prescription bottles or pill pods or safes. Drug disposal sites, every county on the midshore, I think every county in the state of Maryland has drug disposal sites or drop boxes. Often they're at police stations. Sometimes the local pharmacies may have them as well. In our county, I'm in Talbot County, our sheriff's office has a drop box. It's 24/7. You can go any time of the day or night, drop any prescription in there, no questions asked. They also have sharps containers available too, because we don't want people dropping needles into these drop boxes where the police then have to go through and sort them out. Because that is one of the ways we get our data, is by the police letting us know what they've collected in those boxes. Now, I tell people, even if it's not an opioid drug, please get rid of it at a disposal site, because we don't need anything that we can have somebody get into that could get harmed in our medicine cabinets. So even if it's a cough syrup, if it's expired, over-the-counter drugs, please get rid of all of that. At least we recommend twice a year going through your medicine cabinets. Now, if you can't get, let me go up to this real quick. If you cannot get to a drop box, you can get deterra bags and other methods of disposal through your health department. I thought I had a slide in here, but I don't. But they are very easy to use. They're disposable. You open it, put your medications into it, add a little water, and throw it away. It's environmentally friendly. So please look into that as well. Okay, reducing stigma. We want to, we want to remove basically the barriers for getting help. So words matter, and continued use of stigmatizing language keeps people from accessing help. We know that for a fact. So research shows that the language we use to describe addiction perpetuates, I'm blocked off on my thing here. Okay, research shows that the words we use to describe addiction can either assist people, support them, or contribute to the stereotypes and the prejudice. So it does keep them from getting the treatment that they need. So we talk a lot about words matter. We want to use people first language. So we refer to people with substance use disorder as a person with a substance use disorder. Not, some of these awful terms I even hate to have to say, like addict or junkie, boozer, etc. Describe someone as being in active addiction or substance use or in recovery. We don't want to sensationalize it by saying someone suffers from or is a victim of. We try to say the person had a setback in terms of, if they start using again after a period of abstinence. We don't necessarily want to say relapsed, and say positive drug screen. So these are just examples, but in terms of the term relapse, any chronic disease that can be managed, people relapse. People relapse when they have diabetes. People relapse when they have, depression. Chronic diseases, people relapse. It's not a nice, smooth path to becoming abstinent or being in recovery. So we want, again, to look at substance use disorder as a chronic medical condition that can be treated and people can recover. Harm reduction, we talked a little bit about that, you know, things like seatbelts, condoms, vaccines, bike helmets, those are all examples of harm reduction. Okay, so when we are looking at opioids, we're looking at Narcan, fentanyl test strips, medication-assisted treatment like methadone, we talked earlier, syringe exchange programs, etc. Okay, so I believe that's probably toward the end. Do we have any other questions up here? Okay, good. Yes, so Julie has put in some good information here about our courses. This is an overview of the courses and the services that we offer through Rhoda. We have a wonderful website. We have really good social media outreach, especially on Facebook. We have some really, you know, the information is out there. We have a newsletter if anybody is interested in signing up for the newsletter. So this course that you took today is part of the opioid, it's Overdose Lifeline, and that is the Opioid Public Health Crisis course. This is not about drugs course. There are several others. There's one about stigma. There's the one we're going to do in 2 weeks about the brain and the disease of addiction. So we have all of those that are a series of presentations that can go from 45 minutes to an hour. And we can do those in a variety of settings, either in person or virtual. We offer Generation RX, which is the medication safety, and we can offer that from youth all the way up till senior citizens. We have lots of other services. We offer mental health first aid and youth mental health first aid courses, but that's that's about a 8-hour course in total. It requires about 2 hours of pre-work and 4 to 5 hours in class. So please, you know, feel free to send us feedback. Let me give you the evaluation link. If whatever feedback you have, we totally welcome it. We will come to you with these programs. These programs are free of charge to people on the Eastern Shore, particularly in the Midshore area is our target, but we, you know, will occasionally go to other settings and on the shore. So we, you know, hope that this was helpful today. I hope that you come back to our next course. And we are really just pleased to have you all here today. And, you know, if you have any other questions, we can certainly stay for a few more moments and answer them. Good, thank you, Julie. My email is up there. So any questions that you have, if you want copies of the slides, we can certainly provide those. Okay. Terrific. There is the evaluation link. So thank you, everybody. I hope that you have a really great rest of your week, and I hope that we see you in a couple weeks. And take care.
Thank you all. Be well.